All right, good afternoon, everyone. So, as was mentioned, my name is Katelyn Hapape, and I'm here with Derek Jorgenson. We're both faculty members in the College of Pharmacy and Nutrition on the pharmacy side. So, we're both pharmacists, and we had with us on our research project Anne Babu, who was our research assistant that assisted us. So, our project, we titled it Evaluation of the Impact of a Pharmacy School Operated Interdisciplinary Chronic Pain Clinic Using Linked Administrative Databases. So big title there. So we'll break it down. We'll provide some background and then into the results of our project. So we'd like to acknowledge the Health Research Data Platform Saskatchewan for making it possible for this research project that we were able to link the administrative databases in the study. So for a bit of background, many Canadians, 1 in 5, live with chronic pain. And in terms of care for chronic pain, interdisciplinary chronic pain clinics is recommended. However, throughout Canada, access to interdisciplinary pain clinics is very limited. Prior to 2016 in Saskatchewan, we actually didn't have an interdisciplinary chronic pain clinic. In 2016, a clinic did open in Regina, but their care was specific to patients in Regina, and there were limitations in terms of the number of specialist chronic pain clinic physicians available to staff that clinic. So our idea as pharmacists was to adjust the model of care to reflect really the resources available in Saskatchewan to provide care to patients across the province. And so the typical model for chronic pain care in interdisciplinary clinics, often it's physician-led, and then other healthcare providers, physical therapists, social workers, pharmacists are there to support kind of the overall care process. And often in those models, the team members may work individually. There's a lot of silo work where the physician's seeing the patient, then maybe the pharmacist, the other team members. And there may or may not be avenues for close communication and shared work. There may be in the typical model groups education sessions by various team members, but they may again happen in silos. So our thought with the USAS Chronic Pain Clinic was that it would really be led in terms of the care by the pharmacist, physical therapist, and social work team working as a team of interdisciplinary healthcare providers. And given that there was really limited and still is limited clinical specialist physicians in chronic pain, that our physicians have taken a supportive, generally non-direct patient care role in terms of supporting the other team members. And often our team of the pharmacists, physical therapists, and social workers were seeing and are seeing patients together as a team. And then they may discuss the case with the physician. Sometimes the physician's involved in the direct patient care. But mostly it's through virtual appointments. And another piece with our whole program was we really launched right when the pandemic struck. So March of 2020 was when we got our funding, when we got rolling. And because of that, we quickly pivoted to most of our services being virtual, although there are in-person appointments as well. And then we do have group education sessions led by various team members.
Okay, so to put this into context, here's some of the specific services, like what that actually looks like on the delivery level with the clinicians. So we offer individual patient consultations with the entire team. So this is the primary thing that happens if you're a family doctor, you refer a patient to our clinic. There's about a 12-month, 9 to 12-month wait until you get in to see our team. And what happens on that first appointment is the person meets with the physical therapist, the social worker, and the pharmacist together in one group appointment where they spend 90 minutes. It's a 90-minute appointment to collect the entire history of that person. So they only and we evolved into this, but the idea is that many of these people have quite traumatic stories to tell, and in this way they only have to tell it once, and the whole team hears it together. And then in that session, the team comes up with the patient with a care plan going forward, and then typically each individual clinician meets with a patient separately during the 6 months that they're in our program to try to achieve the goals of therapy that are identified related to each of the professions. And we use the 3M approach to care, which is what most other interdisciplinary clinics use, which is medications, mind, and movement. And so each of those professions obviously focuses on one of those M's. to help achieve the patient's individualized goals. In addition to the individualized care the patients are receiving during those 6 months, we have evolved into a large number of group education sessions that the patients attend. There are a couple of them that are mandatory. They must attend 2 group education sessions before they are booked with their first appointment with the team, simply so they show up knowing the basics about chronic pain and the concepts that they're going to talk about. So it really helps them achieve a lot more. We found this has all evolved over the first few years of the program. And then there's a very specific education sessions around some around intimacy and chronic pain. Into mostly being involved is through case consultations. And so what we found was during that 6 to 12 months while the patient waits to see our team, um, a lot of a lot of a lot of interventions were possible that could have been made prior to the patient seeing our team. And so what we started doing was reaching out to the referring provider and offering for them, if they would like, to meet on Zoom with our pharmacist and our physician to talk about the patient they've referred, to get some tips, some ideas, some strategies on what to work on while they're waiting for their patient to come here. And this has become it's completely voluntary. It's become very popular. I think about 60 to 70% of our physicians sort of take us up on this offer, which is a big number, because they spend, usually it's about a 40-minute Zoom meeting with our team, presumably taking up their normal clinic time to do that. And so this has become one of the things our physicians spend most of their time doing, is sitting in on these consultations. And we've just recruited a new physician part-time, and this is the only thing that our physicians now do in person with patients is she has a specialty training in EMDR, which is eye movement desensitization and reprocessing therapy, which is a very specific therapy focused mostly on post-traumatic stress disorder. But we found our patients with chronic pain, almost a large proportion of them come to us with a history of trauma that is very similar to PTSD, and this has been quite effective. So she now provides this in person with our patients. And we also our pharmacists provide cognitive behavioral therapy for insomnia for those who have sleep issues as well, which is very common in this population. I list this, and I'll spend very little time on this, but just to give you an idea what research preceded the project that we're going to share with you today, and to put into context why we needed and wanted this additional data that we got from the HRDP-SK. So we initially did a retrospective chart audit. After the first couple of years, we looked back at all the patients who'd been to our clinic to see essentially what happened to them. At a high level, we found that on average, about 25% of our patients who came to us on an opioid, we switched to buprenorphine naloxone or Suboxone, which is typically used for opioid use disorder, but is also quite effective for chronic pain, tends to cause less side effects, be well tolerated. And so we converted a significant proportion of our patients to that therapy very successfully, which again, for the most part, causes fewer side effects, has less risk of overdose. And those who we didn't switch to Suboxone, on average, we reduced their opioids by, I think, about 20%. Very few came off of them. Their pain got a little bit better, but the thing that we noticed most is their function improved significantly when they reported to us on various sort of functionality global assessments of function scales. They tended to have a much better ability to achieve their daily activities and function better. We did surveys of the people who referred patients to us, mostly family doctors, some nurse practitioners. We found, interestingly, that not surprisingly, that they were very happy with the program because one hadn't existed. So it's pretty easy to be happy with anything new. So that's not a surprise. But one thing they told us that was nice to hear was that they found that not only were they observing significant improvements in their patients after coming to our clinic, but they as a clinician were using what they learned from the case conferences to apply to other patients who'd never been referred to our program. And that was one of our goals initially, to try to increase the capacity of the existing primary care system so we as a province could rely less on specialty care. And so that was a signal that maybe we were achieving that. We did a survey of patients who'd been just discharged from the program and heard very similar things, that their pain was a little bit better, but they tended to have a significant reduction, significant improvements in overall mood, improvements in their daily function, and function, mood, and what am I missing? Those are quality of life were the main things that they reported back. We did interviews with the discharged patients to get again to find out what was their experience, what worked, what didn't, and we've made significant adjustments and evolutions to the program based on those interviews. And we've just finished a survey of the case conference participants. So the initial survey was just of everyone who sent a patient, but we've specifically surveyed the people who participated in the case conferences to get their feedback, and that was wildly popular. People were really, really happy with the fact that they could just have an informal conversation with our specialty team, and the primary benefits of that being that they were able to make some successful changes with their existing patients and apply that to future patients. And then we interviewed our own team members partway through because we were seeing these benefits and we just wanted to try and document what is it about the way our team is functioning that is perhaps contributing to this to this success, so that maybe other teams can learn from how our team is functioning. And so I won't go into it, but we have a whole report I could share. Most of these have been published, and I can share all of it if anyone who's interested. And then finally, we did interviews specifically with the patients who'd been transitioned to buprenorphine, naloxone, or Suboxone, because it's quite a new thing in the chronic pain world to use this as a therapy, and there was very little research um, in the literature on patients' experiences and how effective it is to switch from a regular opioid to this opioid. So we interviewed our patients to find out some of their experiences, and we learned a lot of things we could do better. In general, we learned that from a patient's perspective, this was going in general quite well for them, and supported what was existing in the literature, that this appears to be a useful strategy for chronic pain. So this is all the research we did before we endeavored on this project. And the one thing that we thought was missing was any real objective data, or stronger objective data that we were making a difference in, kind of hard clinical outcomes. And so we were really curious. We were really curious about whether or not we were reducing things like emergency department visits, hospitalizations, and physician billings, because the whole or one big goal here is to avoid some of those things. We know that people who have really poorly controlled chronic pain go to the emergency department a lot. They go to their family doctors a lot. They often end up in hospital for an overdose or poorly controlled pain or whatever. And we were very curious, are we making a difference on these endpoints? Is this where we're going to switch to you? Oh, okay. So that was the overall goal. And so what we what we were attempting to do was use these administrative databases to determine, are we having a difference? Are we having an impact on those endpoints? And so what we did was included all patients who participated in the UCPC service from January 2020, essentially when we started, to June 2023, and those who consented to have their data used for research purposes, which we asked them at each intake. Oh, thank you. These were ultimately the databases that we accessed. I won't list them out, but in attempt to look at hospitalizations, emergency department visits, and physician billings. And so what we did, is this you now? I think this is Katelyn now, yeah.
Yes. So what we did, we sent to the HRDP the individual patient HSNs in groups referred during 6-month blocks. So the kind of index date was the date that they were referred to our clinic. And then for the data extraction, all patients in each block were considered to have the same index date, even though they were actually referred to on slightly different dates, but we had to do it in the 6-month segments. So for the data analysis, we looked at the discharge databases, the primary care visit, the hospitalization rates compared for the 6 months prior to the index date, so prior to them being referred, with the 6 months after they were discharged from UCPC. And then in terms of statistical analysis, this is where Anne helped us in terms of doing the chi-square test and random effects binary logistic regression model. So overall, we had 284 patients who we included, and they were an average age of 55 years old and 68% female. And so for the emergency department visits, the overall mean rate of emergency visits before and after was really not any different. So overall, no statistically significant difference there for emergency department visits. For physician billing, again, the rates were very similar, 17.4 pre, 16.9 post, so not statistically significant. And then for hospitalizations, so this was interesting. The overall mean rate of hospitalizations pre was 0.52 visits before and 0.39 post. And there was a statistically significant difference there. And then to explore this difference in more detail, there was the univariate unadjusted model, which showed the odds of having no hospitalizations post-discharge was statistically significant compared to before. And then when we had Anne look at this adjusted for age and sex, the odds of having no hospitalization post-discharge versus pre-referral was also statistically significant. And so overall, we found that this study does provide a signal that participation in the USAS chronic pain clinic may lead to a reduction in the rate of hospitalizations, but not emergency department visits or physician billings. And the findings really align with the other research that Derek talked about. However, at this point, it would be useful for us to explore this further with additional research. So this concludes our formal presentation. We're happy to, yeah.
I might just add one thing that was interesting, and maybe if I'm not sure what the interest in which part there's interest in, and people can ask questions, obviously. But one limitation we had was in the obviously what we really were hoping to find is there a reduction in hospitalizations, emergency department visits with respect to hospitalizations for chronic pain. But one significant barrier is there was I think there is now, but there was no hospital code, the ICD-10 code for chronic pain. It didn't exist. And so if someone goes into a hospital and they code why they were there wasn't a choice to select chronic pain. They might select migraine headache, they might select opioid use, they might select a whole bunch of things that were actually chronic pain, but they couldn't select chronic pain. And so we wanted the data from the databases on chronic pain, but it couldn't be given to us because it doesn't exist. So we asked for all of the just give us all of the discharge diagnoses, and then we'll try to look through them ourselves because there were, a reasonable number of patients, and try to discern on our own which of those kind of looked like probably chronic pain and which obviously weren't, if it was diabetes or something like that. But if it was headache, maybe it was. And the trustees would not release that level of data to us. And the reason given was that because it wouldn't be very interpretable at the end of the day, which is true, it still would be, we're guessing whether those would be chronic pain or not. That level of data was not given to us. And so we were given sort of all-cause hospitalization, all-cause emergency department visits. So those results represent sort of our impact on all hospitalizations because, So I thought that was an interesting learning I was surprised at first that they refused to give us access to that data, and then it kind of made sense. So, because we didn't need it, so why you can't have it. So anyways, I thought that was interesting, but, and perhaps still the way it goes, but. So yes, we shall take questions if there are any now.
Thank you, Dr. Jorgenson and Dr. Halpape, for your presentation. If there is any questions we can take, and for those who are using Zoom, please put it in the chat box if you have any questions. Yeah.
Yeah, a couple questions. Thanks, guys. It's really exciting to see some of the first results out of the HRDP after all these years of work. Getting the HRDP going and all the work that the teams put into it both teams have put into it, the HRDP team and your research team. And I'm sure as one of the first teams through, you guys experienced a lot of hiccups. You were kind of the guinea pigs, right? So I just have a couple, I'm as interested in the process as I am in the research. And actually both of my questions are more on the process side. So you just said that you were able to get whether patients were hospitalized, but you couldn't get the reason for the hospitalization, essentially. And I'm just wondering, like, did you try to formulate a case to say that like you could develop an index of like in the way that we have like ambulatory care sensitive conditions? Like we take a bunch of diagnostics codes and we have this theory of like which diagnostic codes are most likely to be related to these conditions. Is there, did you guys think about developing an index for like potentially like most likely chronically pain related or high, type index from those diagnostics codes? And maybe that's something for future work, or maybe that's something that somebody else has already developed. That's kind of my first thought, and I wonder if you guys explored that, because it seems to me that might be a way around that, and then you could make a case for that as a research use, right? And then I had another question, which was just a curiosity. Um, why 6 month blocks? Like, what was the procedural or like data reason for that blocking off into 6 months? I'm just curious. I don't have any problem with it. I'm just like, oh, why that? That's interesting.
Uh, There may have been a way around it, and it's a long time ago now we did this because the process has been very slow. Because I think the process was being evolved and refined as we went through it and tested each of the steps. So each step was understandably slow. So I'm not sure I have a recollection of all the details, but we put a lot of thought into that for sure. We looked to the literature to see who else is. When you look at other studies with chronic pain that used administrative data, what did they do? And we did make a case for like here are the ones that we will here are the specific ICD-9 codes or ICD-10 codes that we will consider as chronic pain and the ones we won't. And I know we had a list, and we were very specific around which ones what we would do with which ones, but it was super imperfect because when you look at the codes, that we were going to consider to be related to chronic pain, they could in actuality be related to a lot of other things. And it was just so imperfect that, yeah. So I don't know I don't know if there were any way we could have got around it, perhaps. At a certain point, I think I don't want to say we gave up fairly easily, but it was clear that it was going to be uninterpretable no matter what. If we had that data now, it wouldn't tell us any more about our research questions. So I think we were kind of okay with just having the all cause stuff, even though as researchers, like we wanted to see it all. But I'm pretty certain it wouldn't have helped us answer the question.
Yeah. Yeah, and I think from a clinical perspective, given that chronic pain affects really all aspects of someone's physical and mental health, it actually ended up better for us that we could just see the all cause because it would really depend on how it was all coded there. And like Derek said, for quite a long time, there hasn't been a specific code to chronic pain, and it's very likely that it could have been coded as whatever other reason they showed up in hospital. So I think also just the niche area that this is in also impacted it.
Yeah, I think had we not found a difference in all-cause hospitalizations, we would have always wondered, was there a difference in chronic pain hospitalizations? Because we can't affect diabetes hospitalization. But the fact that despite that, we found an overall reduction, if anything, may make it more powerful, even though, of course, it's observational data and hypothesis generating and so on. So, and the second question, why the 6 month blocks? It was okay. So if I remember right, part of it was we had to go we would take we had to go 6 months forward and 6 months back. So the longer you made that block, the less data we had access to because you had to go forward, right? So if we did that if we wanted to repeat the study today, the first patient we could include would be a patient who was discharged 6 months ago. So you're losing all the people who were discharged in the last 6 months. So if you made that a year, you would essentially you would have a smaller group of people to select from, practically. And then it was also based on the numbers we had and the worry that the individual cell size of data would be too small. So the smaller, if we did 3 months or 2 months, there might be too few patients and it might be more risky from a data protection perspective. And at some point we landed on 6 months.
So I think we initially had thought about 2, but then it was the small amount of data that it would have been too easy. And then wanting to see kind of how long like we could follow these folks. So yeah.
So So it certainly creates a limitation in the data where, the index date is somewhere in that range. And so some of these people who, when we look at their hospitalizations, it was really 8 months since their discharge. And so that will be a limitation in the interpretation of the data for sure. And I think we gave them a smaller frame and they bounced it back to us and said that cell sizes are going to be too small, make it bigger. And so we did that. Yeah. Did we report them in the 6-month blocks? No, they're reported in aggregate. Yeah. It's just the analysis was so when Anne was primarily a statistician because we're clinician researchers. We don't know how to use SAS. We don't understand. And so she did all that. And so it was analyzed in the 6 months blocks and then reported as one group. Yeah. So they compared. Yeah.
And I think that piece was part of the agreement too, right? That Anne could look at the data at that level, but we had to look at it in aggregate from the perspective.
Only Anne saw that data, and even as the PIs, we had no access to seeing any of the data other than what we show you here is all we were given access to.
Hi, guys. Thanks. Congratulations. If I was making a lot of noise back here, I choked on a piece of pizza and it was all I could do not to cough for the whole time. So the results are so interesting. I would have thought physician visits would have been a more sensitive indicator of the type of work you guys are doing. And I just tell you, think I'm wrong. So it turns out that hospitalizations, you've got this sort of, you looked at a number of different outcomes. Hospitalizations is decreased. Do you have a theoretical explanation? Like, is there, why hospitalizations and not ER? So why hospitalizations and not physician visits? Some connected to the type of thing that you think you're avoiding could explain the fact that you see not only this is amazing, but you have some theory behind what you're seeing.
I'll share my perspective and I'll hand it over to Derek. So I think a big part of our role as a team is connecting patients with their primary care prescribers, so their physician, nurse practitioner. And a lot of, we know that chronic non-cancer pain is a lifelong journey that the patients have. So it didn't really surprise me that there wasn't change in how often they're seeing their physician after. And we often, our team will implement kind of the beginning stages or kind of get patients over to buprenorphine naloxone, for example, but then there would still be ongoing follow-up and changes related to that. So that piece overall didn't surprise me. I was surprised more by the Emerge visit. I would have thought that piece would have gone down because we've created stability around their opioid prescriptions and their non-opioid analgesics. But I think the hospitalizations speaks to, I think, the stability that we were able to help people achieve in terms of their chronic pain, but also that secondarily influences other conditions that they have. So their mental health, for example. Many of our patients also have comorbid depression, anxiety. So perhaps aspects related to that, or now that they're stabilized around their pain, perhaps they're able to then focus on their diabetes management more, et cetera. So some of the functional outcomes related to that, I think, maybe is reflected in the hospitalizations. So those are kind of my thoughts around that.
Yeah, I'd say the same thing for the physician billings. In fact, there was a hypothesis maybe that we might increase them because we're sort of sending them. Like we don't prescribe. We forgot to mention. So any medication changes the primary prescriber's got to do. So we're often sending them with a care plan to their primary care people. So we might have even increase that. Maybe that's a good thing. But yeah, I can't get my head around the emergency visits either. One person's thought, I wonder if they're going to Emerge and just getting immediately admitted, and so it's not showing up in the Emerge database, and no one could really answer whether that, if someone came to Emerge and were quickly admitted to an inpatient ward, does it show up in that the database with emergency department visits, or is that only for people who are sort of cared for in emerge and then discharged? Because they would not be discharged from emerge, they'd be just admitted to hospital. And so one hypothesis was that scenario might be missed, and that's what we're seeing. But I have no idea. I feel like they should both be changed. I guess the limitation of observational data, right?
I had a very similar question to Dave's, so I'll ask a different one as well. Is to get the data, I think you had 284 patients, and that was for those who had provided consent, I believe, is what you had showed earlier. How many clients overall were eligible, and how many consented to have their data available to be processed for the research? Do you know those numbers off the top of your head?
I don't. I could find out. It was very high. Like it's uncommon during the intake process that people decline that, but it is not 100%. Yeah. But if I had to guess 90, it's really high. Yeah.
Yeah, and I think that's something that we were really strategic about from the get-go was getting consent around the research piece because of the way the whole clinic is set up as, in a way, a big research project. Yeah. And I think maybe being positioned at the university created more openness to that. That's just kind of my thought related to that.
And the consent was very much, we will use your anonymized data. You know, we had to get, for some of those other projects, we had to get specific informed consent for that project separately from ethics, but for this one. So it was, I think it would have been an easy thing to say yes to, because it's like, we're going to put all your data in a big pool and potentially analyze it. So it was maybe an easier sell. I don't know. Or we had our MOA did it all. So she's also a hard person to not love.
Thank you. Mamata Pandey, please go ahead if you have any question.
Yeah, thank you so much. First, I really want to congratulate the research team on this wonderful work. And the reason I'm so excited about this work, because I was part of the evaluation that was carried out for the Regina Chronic Pain Clinic. And we have since published 2 papers based on what we found from that clinic, the experience of the clients as well as the care providers at the time. So I do have a couple of questions, and maybe if it is too many, we can always connect offline as well. So my first question was for the physician's billing, there wasn't a change. And I'm kind of wondering, would it be because, like, you know, especially what we found in our project was like, you know, if a physician, their family physician or their regular physician would not provide another opioid prescription or a pain medication prescription, in moments of desperation, they would go to walk-in clinic, to anywhere they could to address their pain and their distress. So I was wondering, like, if that would be the reason for why there wasn't a change, because maybe their regular physician would have said the prescription that you have is adequate, but, you know, it was not addressing the current distressing situation. So they might have gone to other providers or any provider who would have, you know, addressed their condition at the moment.
Thank you for your question. So I think something that we thought with the way our program works, because we don't prescribe any of the medication, our team supports their family physician with the prescribing. And so we actually had thought that we might see an increase in physician visits after, because they would be more engaged with their primary care prescriber. So I don't think after, hopefully, because part of our whole team's approach is helping to support their prescriber, that we kind of see when we get a referral, we have 2 clients. We have the patient and we have their primary care prescriber. So we put a lot of effort and weight into supporting that prescriber. So I guess my hope would be that they aren't seeking out other prescribers after being involved in our clinic, but we can't break it down based on who they were seeing after.
Mm-hmm.
Oh,
Yeah.
I'll just add one thing. The other thing, we also sent a survey to all of these people, and I think about 60% responded. And then we interviewed about 20 of them, did like one-on-one semi-structured interviews, and that signal didn't come out. Doesn't mean it wouldn't have happened in some of them, but that didn't come up. So it wouldn't have, I don't think it would have been common, but it's a good thought as a possibility for sure.
Mm-hmm. Yeah. So my other question was like in the very beginning, in terms of the demographics, like it was the age range and also the gender. And you did mention that many of the clients also experience associated mental health issues, that the mental health issues could have come before or could have come as a result of chronic pain. So I was just wondering, was that one of the variables that you considered? And do you think that could have, like, teased out the results a little bit differently, maybe, if that factor was considered?
So I guess for this specific data set, this part with the HRDP, as we didn't have the diagnoses for the patient, we didn't have that here. But in some of our other analyses, for example, our chart audit, and even the surveys with the patients, we were able to gather information around their overall improvements in function, and some aspects related to their overall clinical functioning. We did the patient global impression of change, which kind of is a holistic outcome of their mental health and overall well-being. So we did look at aspects related to mental health outcomes in other parts of our overall evaluation.
Awesome. I would be interested to connect offline if there is an opportunity, because I did have many other questions as well. But I'll save it for later. But thank you so very much.
Yeah, I think our emails are on there, so feel free to reach out. We're happy to share everything we've got or discuss further. Absolutely.
Thank you. Jones, do we have any question in the chat box?
Hi, I'm not seeing any questions now in the chat box.
Okay. Thank you.
And I guess I'll add for the HRDP folks, we're presenting this data at an international conference next month, and it was selected as one of the keynote research presentations for the conference. So it speaks to the impact that having access to this data has, certainly provincially. The other thing we sort of left out was our funding situation. Like, we were originally funded with a research grant from the Federal Substance Use and Addictions Program, and we've since used this data, including, we had preliminary results from this study and used it to negotiate with the provincial government to fund us so we are now a fully funded health service for the province of Saskatchewan by the Ministry of Health, in part because of all of the data we've collected, including these data. So yeah, access to this HRDP SAS data has been really useful to us, and it is being seen as very interesting on an international stage within our discipline. So thank you for that. I didn't know if you knew that, but yeah, no, it's exciting. Yeah, so, yeah.
Congratulations, and thank you for mentioning that. We appreciate it. Yeah, Jones, do we have any question?
Yeah, it looks like in the chat, Katie has a question. She says, you discussed patient complexities and comorbid conditions. I wonder if you captured this patient profiles that include common comorbid conditions, i.e. cardiac, for example, that might lead people to EDs for reasons outside of the pain presentation. I think you explained well the reasons for ongoing physician billings.
Thank you for that question. So overall, with this HRDP data, we do not have the diagnoses of the patients, and we've kind of described that a bit in terms of how we were not able to access that. But in our other data, some of our chart audit data, for example, we have looked at some of the comorbid conditions that the patients have.
And we did do, I think in the chart audit, like some subgroup analyses to see, was there a difference in a lot of the endpoints we collected with respect to certainly people with pre-existing mental health diagnoses. I think by age, by referral source, people can self-refer to our program, so you don't need to get referred by your physician. There was a sense maybe those people would be more or less engaged. And we didn't see any differences in that data, because of course we had access to all that data because we asked them. And so we're very confident in it. But from the perspective of doing subgroup analyses with this data, it sort of was we just had no ability to do that. Yeah.
Thanks. Thank you again, Dr. Jorgenson and Dr. Halpape, for your time and for your presentation. Thanks again and congratulations. And now there is a pool that Jones will pull up for those who are using Zoom that we appreciate your feedback on the subjects that you would like to see in our next community of practice sessions. And yeah, Jones will pull up, and that would be great if you can have your suggestions or any idea you have. And also we have a kind of sticky notepad there for the people who are in the room. If you have any suggestions, it would be, yeah. And also we have, yeah. Thank you.
Yes, I'll leave this poll up for a little bit. So if you don't have any suggestions, feel free to just write no suggestions in there too.